Morning all. I'm really looking forward to this next session, and it's very personal as well because we're treating our president of bias, and I can assure you all he has given his consent for his case to be discussed. Got really eminent speakers in this session. We got Professor Chris Wilson from University Hospital of Wales and Professor Hemant Pandit from Leeds Teaching Hospital, and they both have extensive academic and clinical interest in topics of HTU and partial knee replacement surgery. Have a next slide, please. So that's our outgoing president, BJ, and upcoming president, Prof. Talat. And you can see they stick to a type, really. They're 50-something. I hope I got the age right. And they both want to stay very active and have medial compartment knee osteoarthritis and pain. So let's see what my colleagues, Prof. Wilson and Prof. Pandit, offer this to them. So first speaker will be Prof. Chris Wilson from University Hospital of Wales.
Ole, can you hear me?
We can.
So I'm just going to give a 10-minute presentation on the topic in general. Is that okay?
Perfect. That's perfect.
No, let me navigate. So you can all see that, can't you? So we're going to talk about whether to do a uni or an osteotomy, and it is often quite an issue. First of all, we all know, most of the orthopedic surgeons listening to this will know that total knee replacement is not the answer for lots of our patients, particularly the younger ones. It's now well established that the level of function with total knee replacement is not ideal, particularly in the under 55s, so the results are very good. And partial knee replacement and osteotomy both offer better prospects in terms of proprioception, fast walking, athletic activity, etc. So some patients have a unicompartmental disease, and we want better function, and we're all familiar with these x-rays, and we at the outset have to distinguish or think separately between the arthritic change and the actual deformity, and it's important to have a clear idea of which is the dominant factor. Now, I wouldn't argue that all deformity is pathological. We know that most high-level footballers have got very varus knees, some more than others. So this is not an argument that we need to treat deformity per se. But we know that pathological varus always progresses. And when a patient reaches a tipping point, for example, loss of neuromuscular control or a ligament injury, maybe articular cartilage damage, we know that established varus or valgus tends to progress. And this is well established in the rheumatology literature, actually, especially by Sharma and Felton. And they've shown fairly clearly that if you have a varus knee or a valgus knee, is someone advancing the slides? Or I'm not doing it. Once you have a varus or a valgus knee, it always progresses. So we've got an issue of, first of all, do no harm versus waiting the inevitable. And so we've got this concept of a tipping point. At what point should we intervene, realigning the limb? At what point can we save the day? We do know, and it's no surprise, but there's a lot of literature to show that you get increasing articular cartilage loss with increasing varus or valgus. So it's a mobile situation. Now, this is Roman Sales' slide, and we can see here that the traditional view of osteotomy is there's a very narrow window of opportunity, a narrow window of treatment, if you like, in between the biological and the arthroplasty options. But I want to argue that this window of opportunity is actually a lot broader, and we should consider osteotomy in early disease and in later disease. So this is an example of a chap who's had an osteotomy on one side for what we might consider end-stage disease. And we can see here that the straight leg functions well. The unoperated leg has a visible varus thrust. So osteotomy, apart from treating symptoms, it also will preserve the joint. It's going to give us a high functional level. We're going to be offloading the painful or degenerative area as our primary goal. but also secondary goals are relieving instability and, best of all, avoiding arthroplasty. Now, why is osteotomy so much better now than it used to be? Well, that's because we plan it better. We make a plan, we correct to appropriate levels. We know where we want to put the weight-bearing line. There's much more emphasis on measuring angles, planning osteotomy. So this is helping us achieve better results. And in addition, our methods of osteotomy are so much better than they used to be. Picture on the left is an older fashioned Purdue plate. Pictures on the right are these fixed angle devices we now tend to use. And these are a big step forward because they make for rigid fixation, no brace, no plaster, and very early rehabilitation. So that's contributed in a lot to the, let me just go back there. That's contributed a lot to the success of osteotomy. Now, osteotomy also has a biological effect. I just want to show you a couple of slides, a biological effect that obviously a joint replacement wouldn't have. This is a 22-year-old. He had intractable osteochondritis dissecans, fixed many times, actually 4 times, and basically leaving a large hole in the lateral femoral condyle, a pre-arthritic lesion, you might say. And we see from the long leg views that he had some valgus malalignment, and we see from the plain X-ray there's a large hole in the lateral condyle. Now, when he came to me, we didn't do anything to the hole in the femur. We simply did an osteotomy and corrected his axis. And you see that 3 months after his osteotomy was the MRI scan shows some healing of the lesion. And 3 years later, the lesions disappeared arthroscopically as well, and he's got a high Oxford score. And you could say that we've reversed the natural course of events in that knee by simply altering the mechanical environment. Now, results of modern osteotomy, it's often said that they're patchy, but that's not the case. Over 85% good or excellent at 15 years, pain relief better or as good as knee replacement. Obviously, a better level of function, a very good Oxford and Coos scores. Look at some cases then. This chap's a keen runner. He's 50 years old. He's got a knee that many of us would consider a uni would be a much more direct solution. He's got end-stage arthritis medially, a little bit of varus arising from the joint, and a little bit of metaphyseal varus. That's important, as we'll see later. Now, we did in him an osteotomy, much slower recovery than a uni, longer rehabilitation, but returned to a very high level of function with some visible recovery in the medial compartment. Now, this reveals the sort of central, I think, important point about osteotomy. If you're considering someone for osteotomy, you do have to, in my opinion, have a starting deformity. I think osteotomy in patients with no deformity, no metaphyseal deformity, is quite risky. In terms of indications, however, we've got to think in terms of exclusions. So the exclusions will be widespread arthritis, very severe fixed deformity, poor healing, diabetic or a heavy smoker, no metaphyseal deformity, but things like age, gender, stage of disease, BMI, later arthroplasty make no difference at all to the outcome of osteotomy. And that little table on the right there is a result of a French study, which shows that with increasing metaphyseal varus of the proximal tibia, the results of osteotomy are better and more predictable, as we might expect. Indications for uni, well, we all know about those, but really we want grade 4 disease. We want isolated disease and a neutral alignment. But importantly, we want a patient with quite modest expectations, a relatively sedentary but high functional lifestyle and intact ligaments. So if we're looking at a patient deciding whether we want an osteotomy or uni, we have to get certain things clear in our mind. Are we treating pain or instability or both? How much deformity is there? What's the starting deformity? Is the loss on X-ray partial thickness? And what does the patient want to do? Because osteotomy involves quite a bit of rehabilitation. Uni is a much more direct solution. Don't forget that even Oxford themselves say that in partial thickness disease, unicompartmental knee replacement offers unpredictable results. Some cases then. This is a colleague of mine, 52-year-old. As you can see, really quite end stage lateral compartment osteoarthritis, but importantly, a very valgus knee. Couldn't do all the things she wants to do, like running and walking. So in her, despite the severity of disease, we did a realignment osteotomy, and she's 8 years down the line and can still function at a very high level. Now, this is buying her a little bit of time, but you know, the result at 8 years is much more satisfactory than it would have been with a joint replacement. Conversely, this lady, who's a very high-level hockey player, has got lateral compartment osteoarthritis, as you'll see from the Rosenberg view there, but she has very little deformity. So she's not a good case for osteotomy, despite a high level of function and high functional aspirations. So she's had a very good result from a lateral uni and can still run a bit, but she's had to accept the fact that the international hockey days are over. This chap came to see me recently. He's a mountain rescue person at the age of 69 and wishes to continue in mountain rescue. And he's got a very varus arthritic knee, but he's got a very high level of metaphyseal varus in his proximal tibia. And therefore, I would consider that for him, despite his age, osteotomy is the better option, because that's the only thing that will keep him going up and down the mountains and his rescue. But there we are. But conversely, this chap, who's much younger than him, 58 years old, he's an office worker and a golfer. He's got very little metaphyseal deformity, and he can't really be bothered with the rehabilitation either. He wants to wake back quite early. So for him, a unicompartmental knee replacement is a much more direct solution. Now, don't worry if you're doing osteotomy about conversion. There's a story amongst orthopedic surgeons that your subsequent knee replacement will be more difficult. And I've not found that to be true at all in 15 years of doing these conversions. And in fact, the literature supports that. There's no evidence that total knee replacement after high tibial osteotomy is any more difficult than a primary knee replacement, especially in view of the fact that nowadays we're doing lots of open wedge osteotomies, which in a sense create additional metaphyseal bone. So in the final analysis, you've got a patient in front of you, you're trying to choose between the two things. What are you going to do? Well, decreasing age pushes you towards an osteotomy, but the age group of 50 to 65 can be tricky decision making. But if the patient wants a very high level of function and wants to run and lift heavy weights and go up and down mountains, you know that a knee replacement is not something that that's going to deliver that level of function in most cases. However, if they present with this dilemma and they don't have a metaphyseal deformity, my advice would be don't do an osteotomy, because you'll need to overcorrect them and you'll get an unhappy patient. Conversely, if they present with an arthritic knee but the joint space loss is very minimal, don't do an arthroplasty. Always bear in mind that the rehabilitation after osteotomy is longer and more arduous than rehabilitation after a joint replacement. So you have to be sure that your patient knows that and can buy into it. So there we are. There are overlapping populations between a uni and an osteotomy. High deformity, desire for high function, partial thickness loss pushes us in one direction. Full thickness loss, moderate aspirations, and no deformity pushes us in the other direction. There is a population of patients in the middle who've got full thickness deformity. They wish to have a decent level of function, and they've got some deformity. Well, they present the treatment dilemma, and you have to put the options to the patient, I think. Thank you very much.
Thank you, Chris. I would next invite Prof. Hemant Pandit, and he'll lay out case for partial knee replacements.
Thank you, Sanjeev. Can you hear me?
Yes, we can, Hemant.
Okay, thank you. Martin, am I allowed to share slides?
Yes.
Okay. Give me a minute. Struggling to share slides, I don't know why. You must have my presentation as well.
We do have your presentation.
Don't mind if you want to.
If we can.
Earlier, Sanjeev, I apologize.
No worries. Can we get Prof. Pandit's presentation running if it's possible? Okay, thank you. While we're waiting for,
Yeah.
we have some questions. I've got Mr. Amit Chandratre with me. He'll ask us questions while we're waiting.
Hi, Chris. Are you?
Hello.
Hi. Yeah, there's a question here that do you ever consider osteotomy below tibial tubercle if the deformity is severe? I suspect it's a biplanar question they're asking.
Yes. Well, some of the orders will be familiar with biplanar osteotomy. Others won't. This is a technique where we make a coronal cut to go behind the. Hang on, stop my video. We make a coronal cut to go behind the tubercle. Now, with a very high deformity, we don't want to drag the tubercle down, so the coronal cut goes inferiorly. So it's called inferior biplanar. It adds something technically because in order to prevent the quadriceps pulling the tubercle off, we have to fix the tubercle separately. And I tend to use an inferior biplanar if I'm going to do an open wedge correction of more than 15 mils. 50 mils is very big corrections, quite rare. But if you are not someone that does biplanar, you have to make an assessment of whether your osteotomy is going to significantly alter patella height. And if it does alter patella height, you have to try and arrange things so that the tubercle is on your proximal fragment. Now, that's actually quite a difficult thing to do with a proximal tibial osteotomy if you're not using a biplanar technique.
Okay, I think I've got that covered later on.
Okay.
So I think we got.
Slides?
Okay, Hemant, I think you on. Yeah,
Can you see the slides?
we can.
Okay, thank you, and I apologize. So, first and foremost, thank you, Amit, thank you, Sanjeev, great meeting. And Chris, I must give him credit. He has given a very balanced view, and I don't disagree with anything that.
Hemant, can you go full screen, please?
Yeah, sure. Yeah.
Yeah, thank you.
Okay, thank you. Sorry, I have messed this up. I have a feeling. Give me a second. Okay, I think we'll go with this. Let's see, because the full screen doesn't show everything I wanted to show. Anyway, thank you. So, I must give credit to Chris. He has given a very balanced view. I don't disagree with anything he has said. I'm going to compliment some of the things that he has said. And I think I'll try and keep this discussion, this presentation short so that we can have some good discussion. Thank you. So most of us have seen these slides, some of these slides before. This is an original patient from Goodfellow series, severe arthritis, bone on bone, medial compartment. She does have tibia vara, but clearly she's not suitable. Even if she was 50, I would doubt whether she would be suitable for a HTO. So in my mind, and clearly the deformity was correctable when she applied valgus stress to the knee herself. And more importantly, when she sat down, the deformity did get corrected because there was bone posteriorly on the tibial condyle. This is the patient's X-ray, which to confirm that it has all the necessary classical features of medial compartment arthritis, intact ACL, affected patellofemoral joint, and intact ligaments. So to diagnose anteromedial osteoarthritis, you do need bone-on-bone arthritis in the medial compartment with functionally intact compartments as well as ligaments in the rest of the joint. And to do so, we would always depend primarily on plain X-rays rather than on MRI scan. When we start our journey with uni knees, probably you need to do stress radiographs because they are helpful for you to identify the right patient. It shortens your learning curve. Importantly, you can talk to the patient, counsel the patient better, and therefore it helps both the parties and expectations are better. Of course, as you move on with your practice, you can confirm the findings intraoperatively anyway. and more people will go away from doing stress views more for logistical reasons rather than anything else. Uh, I'm always wary of any designer series data, so I think this data is very useful. This is an independent series from Ulswart, 35-year plus experience, 1100 patients, p-bits, none lost to follow, and he has shown that in his and in his center's hands, the 20-year survival is in high 90s. All comers, you can see the age range is wide, so quite young as well as quite old age, with mean follow-up at that time was 6 years. I have a feeling that I have started with some wrong slides, but it doesn't matter. It will still convey the message. The patients are able to get excellent function. They are able to squat as well as sit cross-legged, able to do most of the day-to-day activities. I agree with Chris. If you ask me whether they'll be able to do very high-level sports, the advice is not to do them. We did talk to patients who indulged in high level activity. What we noticed is what we tell the patients, they don't listen to you. If they want to do it, they will do it. And when we reassessed our cohort of young patients who were indulging in Tegner level 5 to 8, they did not have high failure rate and were able to continue to indulge in these activities on a regular basis. Probably more importantly is to understand the clinical outcomes. This is against total knee replacement, and as all of us know, unis give better outcomes than total knee replacement when it comes to Oxford knee score, and the number of patients who have excellent outcomes are far more than with total knees. Satisfaction is better, EQ5D is better. However, more important from the patient perspective are major complications. So the complications of DVT, infection, stroke, MI are far less in patients undergoing uni as compared to total. I don't have similar data with age and gender matched patients in HDO, so I can't comment on that, but I guess in young and fit patients, those rates are quite low. Any operation does have complications, so we need to be aware of that, bearing dislocation, fracture, and we need to be aware how to minimize those risks by taking various steps that are necessary. Progression of arthritis is another key complication which tends to occur with partial knee replacement, but it can of course occur with high tibial osteotomy as well, especially if you overcorrect or damage the medial collateral ligament. When it comes to whether one should do fixed or mobile bearing, it is entirely up to the surgeon to decide what he is more comfortable with. I think the results are quite similar in the two groups in independent series. If you go to designer surgeons or those who strongly believe in doing one over other, they will continue to do mobile bearing. But we recently published this work where we looked at a significant number of patients. And what it showed is that there is no real difference between the two when it comes to the revision rates. Polyethylene, but the mode of failure is different. So for mobile bearing, it is bearing dislocation, while for fixed bearing, it is polyethylene wear. A number of cases is important. I'm going to skip that. So the take home message from my perspective is probably whatever you want to do it regularly. Remember that the patient is on a continuum, and patient, as Chris very clearly pointed out, patient can present at different time points in the continuum. So we really need to know what are patient's expectations. And if the expectations are for moderate function, I would be very happy to do a partial knee. If the expectations are for a very high level function and patient is looking for a temporizing procedure with a clear extra articular deformity, then the answer is going to be HDO. I agree 110% with Chris that we would never ever, or we should never ever offer a partial knee or any arthroplasty to patients with partial thickness cartilage loss. But by the same definition as Chris said, if there is no extra articular deformity, then I really don't see a point in doing a high tibial osteotomy. I'm going to stop here, and I apologize for some issues with the slides. Thank you.
That's wonderful. I was hoping there would have been more disagreement from your side with Chris, but you both seem to agree. Can I have my slides as well, please? I mean, what we seem to agree is that patient with severe cartilage loss, grade 4 arthritis, metaphyseal deformity, high demand, we're looking at more of HTO, but with no deformity, moderate cartilage loss, we're looking for HTO, but severe cartilage loss and no deformity, less demanding, we're looking for partial knee replacement. So what are you going to offer to my colleagues over here? I mean, they're 50-something. They both want to stay active. They want to run. They got medial compartment arthritis. So I can say, ask Chris first, what would you offer to one of my colleagues, these colleagues? Chris, can you hear me?
Right. I've just unmuted.
Okay.
I'm struggling with Zoom like anybody else of my age. Well, now, your colleagues, I didn't see, did you show their x-rays before?
Okay, there you are.
Let me just,
I mean, obviously, there are radiological parameters, but there's a lot about patient profile, as you mentioned, isn't it? That's where a lot of discussion comes in. So both of these guys want to do marathon running.
Yeah.
So what do you think?
Look, let's look at the factors in favor of osteotomy. There is a metaphyseal deformity. It's only looking at that, I'm guessing 4 or 5 degrees, and the weight-bearing line is through the medial compartment. So in that regard, osteotomy is feasible. I would also say you've not done a Rosenberg view, but it's not full thickness loss. The patient also has got a level of function and ambition that outstrips any form of joint replacement. So in that case, I'd be happy to offer that patient, your colleague, an osteotomy. Bearing in mind, as a runner, you have to accept the much longer rehabilitation. You have to be honest with the patient about that. So on the specific issue of that case, I would offer your colleague an osteotomy and promise him that he'll be back to running in about 6 months, all being well. I'm presuming he's not a smoker and there's no other reason that his bone might refuse to heal. Just while talking, I would take issue with one comment from the previous talk, in that osteotomy is not always a temporizing procedure. And in my experience, doing it in early disease, and I showed those cases of, if you like, the biological effect of osteotomy, we haven't got enough to write up yet, but we will in due course. Some patients with early arthritis in effect are cured. Their arthritis progression stops. We see some regeneration. There is an evidence base for it. So I think that it shouldn't always be considered as simply temporizing.
Okay, thanks, Chris. Hemant, you mentioned that you find that uni patients sometimes are doing more than what we think they would do. So would you offer uni to my colleague then?
So far, I mean, I take on board what Chris has said. That patient's on the scanogram and what X-rays you have shown me, I am not convinced the patient has significant deformity. It is borderline, but clearly my field is more skewed to the knee replacement rather than osteotomy. So it has to be a balanced discussion with the patient. If the patient wants to go back to running, understands that it will need longer rehab, then I am more than happy to refer this patient to somebody like Chris or to you, Sanjeev, or whoever do the osteotomy on a regular basis. I still remain to be convinced. I have heard many conversations and many presentations. I have no doubt that osteotomy does well in patients who have partial thickness cartilage loss in the mid to long term. And I agree with Chris that it does stop the progression of the disease. Similarly, there are various studies which have shown that even unicompartmental knee replacement will reduce the progression of arthritis. You do get caught out in both the scenarios. If I was the patient, I would probably stop running, first of all, and I have to change my activity level. Secondly, I think the X-rays do show bone on bone. I mean, they will definitely show bone on bone arthritis if you either do a Rosenberg view or a stress view. So I don't believe this is partial thickness, but I would like to confirm that on the X-rays.
So,
Thank you.
so would you ever depend on MRI to confirm? Can I, slides, are they coming? Or is just X-ray kind of diagnosis for looking at arthritis? So we did MRI. I mean, do you ever depend on MRI, Chris, to look at cartilage loss?
Actually, MRI is my workup for both uni and for articular and for osteotomy. Really, to look at the health of the contralateral compartment and to see, in the case of HTO, whether there's an intact lateral meniscus, which I think is quite an important factor.
Okay.
Particularly for osteotomy. One of the advantages of a partial knee replacement is that you can leave the knee in some varus or valgus if it's a valgus knee, but usually leave it in some varus so as not to suddenly overload the lateral side. But with an osteotomy, although we're looking, it's very important to avoid overcorrection. If we correct to a neutral axis, then of course the lateral side will take a little bit more load than it's been used to. So that has to be borne in mind. But for these MRI scans, I think probably show that parts of the medial compartment are full thickness loss, and you wouldn't feel too guilty about doing a uni in this patient. But I'll go back to the fact that there is some deformity, not a huge amount, but some. There is scope for axis correction. The patient's young and aspires to a high level of function, and that will push me in the direction. This patient represents someone who's in that overlapping group, doesn't he? And that will push me in the direction of an osteotomy. I would do osteotomy for this patient.
So, Chris, can I ask, like, he's got a radial tear of lateral meniscus with some lateral osteophytes. Does that worry you when you do osteotomy? I guess, Hemant, that won't worry you for your uni. Is that right?
No, it won't worry me. My uni, I'll just make a point I forgot to make. I apologize to digress a bit. Chris did show X-rays of post-HTO total knee replacement, and I know with the modern techniques you probably will get away in most of the cases with a straightforward total knee replacement. You don't have issues with patellar tendon length, etc. I would caution you about changing a post-HTO patient to a unicompartmental knee replacement. So that needs to be discussed with the patient, that you then don't necessarily, so you're probably burning the bridge of unicompartmental knee replacement if you have performed HTO before. There are some series which will talk about it, especially if you have undercorrected. I would just have a word of caution. Coming back to your osteophytes and lateral meniscus, if intraoperatively the lateral compartment has full thickness cartilage, I won't worry about it.
Okay. Very quick one, Chris. We're running out of time. So, what does that worry you? Lateral radial tear, lateral meniscus? Yes. No?
Well, I think it's a factor, but then it's a bit like cookery, isn't it? You know, there are lots of different ingredients here. I think it'd be very important. It's always important, but especially in this case, to avoid overcorrection. So we're looking for a neutral axis, despite the fact that there's full thickness loss there. We're not looking to put the weight-bearing axis lateral to the spine. We want it through the spine. But in that regard, I've found that the effect of axis correction is so powerful that it has almost, if you like, changing the mechanical environment of the knee has a biological effect. There's no two ways about it. So I think that despite it's noteworthy, but it would not put me off doing an osteotomy in this patient.
Okay. And just a quick one, audience question. Patellofemoral arthritis, does that worry you? I mean, I guess unless it's severe lateral patellofemoral, does that rest worry?
It doesn't. No, I think the same argument applies to both medial uni and high tibial osteotomy. If you've got a very severe lateral facet and overhanging beak of bone, you know, of the type that we all know, then pushing the patella even further laterally with either technique is likely to result in some problems. So the only type of patellofemoral area that worries me is really quite severe lateral facet with overhang. Everything else I effectively ignore.
Hemant?
I agree with Chris. Same applies to partial knee. I just want to make one quick comment, Sanjeev. So clearly, for Chris and for me, there is potentially a patient who has, say, more or less partial thickness cartilage loss, maybe some areas of exposed bone, but no metaphyseal deformity. Okay? And both of us would be wary of treating these patients. I just want to say something here and probably advertising something here is that the Dutch would very clearly, and again, any surgery, the indications you start with, like onion peel, isn't it? You start with the golden indication and then you try to expand. So the Dutch would, in those patients, do knee distraction. So we are embarking on the distraction. It's called knee arthroplasty versus distraction study. It's an NIHR funded study. And in those patients, so if your patient does not have major deformity, and patient has always lived with a touch of tibia vara during his growing years, a knee distraction is a potential option with similar outcomes that you would expect with HTO, but the numbers from the Dutch are small, 500 odd patients. So I'll update you with time. Thank you.
Thanks, Hemant and Chris. A really interesting discussion. There are a lot more questions from audience, and maybe we'll pass them to you. But I'm afraid we'll have to close this session. Thank you for your time.